So when we're talking about the signs of labor, we're going to talk about true versus false labor. So basically, when you're thinking about like those Braxton Hicks contractions and whatnot, things are happening. We're not denying that at all, but the cervix hasn't done anything. The cervix isn't dilating. The cervix is not effacing. And we really need that cervix to, have an active role, seeing as it's our outlet, our way out of the world. And that's what happens with true labor. We see changes occurring at regular intervals. They increase in frequency and duration, and they show progressive dilation and effacement of the cervix. So the start of labor is influenced by uterine stretching, the withdrawal of progesterone. Progesterone is the hormone of pregnancy. The progesterone is keeping it all together, okay? We have increased oxytocin sensitivity. Literally, the number of our oxytocin receptors increases around the time of term delivery. And we're going to be using oxytocin, or that love hormone, during the laboring process and also shortly to follow during the breastfeeding process. We also have increased release of prostaglandins. Prostaglandins. Remember those? We talked about those a little bit in postpartum, that we use Motrin for, it's a prostaglandin inhibitor, and why that's all so important. Well, that's great for after delivery, but during delivery, we want prostaglandins. These are going to cause our contractions. They're going to get all of our muscles involved. They're going to say, hey, let's go. We're doing this thing now, okay? They help with that cervical softening. And they also deal with gap junction induction. So all of those proteins that are connecting the cell membranes and that are facilitating coordination of the contractions and the myometrial stretching, all of that is due to prostaglandins. We want our uterus to be effective during the laboring process. We don't want it to peter out. So we need, obviously, those prostaglandins behind the scenes doing their thing. They also sensitize that myometrium. Again, gearing up that whole muscle component. So we have increased release of those prostaglandins. They're produced in the decidua, and they're also produced in the fetal membranes. In addition to those myometrial changes that I just talked about, it also helps to reduce cervical resistance. So do we want a cervix that resists change? Absolutely not. We want a cervix that is receptive to change. And so we have more receptors thanks to this increased release of prostaglandins. The whole point of all of that is really to lead to that cervical dilation, that opening of the cervical os, allowing for that fetus to escape or labor out, whichever way you want to look at it. So we're going to break things down. We're going to break things down from stage 1 to stage 4 of labor. Stage 1 is true labor until full dilation and effacement. So true labor, what was true labor again? It was seeing those progressive, regular, actual changes, right? We have full dilation at stage 2 until we have a successful delivery. Stage 3, hey, we can't forget about that placenta. Like, things just haven't ended, or what have you at this point, because we don't have because we've got baby. We still have this whole other organ that needs to get its way out of the passageway as well. And recovery, which lasts at least 2 hours after labor. Some ladies need a little bit more time, and that's okay, but at least 2 hours following delivery. So we're going to break things down even a little bit farther. Stage 1 consists of 3 phases. So latent is 0 to 3 centimeters. Now, you're uncomfortable for a first-time mom, okay? And this is more of like a visceral pain. It's a cramping contraction kind of a phase. And what's happening here, we've got that stretching going on of that lower uterine segment. Okay? Suddenly, this whole thing has to, this uterus, which was just, small pear-shaped sized organ, way up here, now all of a sudden has this potentially, 7-8 pound baby hanging out inside of it. It's stretched completely out. Well, now we have to make room for it to descend down into that true pelvis along with the baby, right? So we've got this stretching and this thinning of that lower uterine segment and cervix. Usually during the first stage, at stage 1, this is when those membranes are typically ruptured. Okay. Now, with that being said, full dilation, 10 centimeters, engagement cannot occur until we have the dilation of that full 10 centimeters, right? So, if we're going to break on our own, it's going to be about this time. So latent is the start of true labor until we reach that 3 centimeters dilation. Contractions are about every 5 to 10 minutes. They last about 30 to 45 seconds. Effacement, are we completely effaced at this point? Is our cervix completely thinned out? Heck no. Especially for our first time mamas, we're at about a 0 to 40%. Are changes happening? Yes. But are we there are we ready to go? No, we're not. Okay. Our uterus is like, give me a second to catch up here. Intensity of those contractions, mild to moderate. Primips, this whole latent phase can last 9 hours. Multips, around 6 hours. Okay? So, for me, first time pregnancy, I go in, I'm excited, I've been contracting since 1 a.m. It is now 6 o'clock in the morning. I let my husband sleep. I thought I was doing a good thing. And we get to the hospital and they were full. For those of you who all of you will be doing your clinicals at Swedish American, this is a very real possibility for patients showing up for them too. So I get to the hospital and they say, yes, you're laboring, go home. You need to labor down. Laboring down meaning the nurse is telling me that my baby needs to descend further into the pelvis. Okay, the station here is usually a little bit higher. We need to allow that as the baby lowers, as that head presses against the cervix, then we're going to have that widening and that thinning again of the cervix. And like I said, in primips, it can take a full 9 hours. So why are you going to sit here and take up a hospital bed? Okay, fine. Not exactly what I was thinking about, but sure. So go home. I tried to nap. I tossed and turned. You're uncomfortable, but it wasn't the worst thing in the world. I remember just throwing off my bra once I got home, oh, that was a waste. So glad I put that on, kind of a deal. Then we move into this active. So this is kind of when I woke back up from my little nap and was like, okay, it's time for us to head back to the hospital. So when we're in this active phase, contractions are about every 3 to 5 minutes. They last around a minute, so 40 to 70 seconds. Our cervix is now dilated to about 4 to 7 centimeters. We are 40 to 80% effaced. Our intensity is moderate to strong. So again, chin to forehead. Oh yeah, stuff's really happening now, right? Primips, about 6 hours. Multips, around 4.5. So when I got to the hospital, at that point, I think I was 3 centimeters dilated, 3 or 4 centimeters dilated. They literally could have said go home, but they did let me stay at that point. But Jonathan did not end up being born for a full almost 12 hours later, I want to say, that he was born. So, it still took a while after we got admitted for me to be able to go from this active phase until, stage 2 of the delivery. Transition is when we are really, really uncomfortable, okay? During transition, you're moving to that 8 to 10 centimeters of full dilation. Contractions are every 2 to 3 minutes, and they last 45 to 90 seconds long. So if you have a contraction lasting a minute and a half, and you're having it every 2 minutes, you have about 30 seconds of recovery, potentially, before your next contraction occurs. That's not a lot of time to grab your breath. This is where our ladies can have this nausea, the vomiting, the trembling of extremities as your whole body kind of goes into this phase. This feeling of loss of control, it's in your textbook, but I don't think that that's rocket science. Increased irritability and apprehension. Again, these are your funny moments that you see comedic relief on TV about, hitting people and saying horrible things to your partner. But this is really where a woman is uncomfortable. The cervix, like I said, dilates. And following this full transition phase, that cervix has to be 100% effaced. So now we move from 80 to 100%. We've got very, very strong intensity. So we've got that increased pressure on that rectum. Now that we're at a full 10 centimeters, our baby is fully down into that true pelvis. We're going to be feeling more of that engagement. And we're going to talk about a little bit here about that pressure on the rectum. The urge to push with baby number 3, this was very, very apparent to me that it was time to push. Like, I was antsy in the bed that we were ready to go. Primips, this should be about an hour, but it should not last more than 3 hours. If you've got a mom in the transition phase for about 3 hours, you need to get her out, okay? Her body is becoming exhausted. She is physically, emotionally exhausted. You're not going to have a successful delivery with a physically and emotionally exhausted mother trying to push. Multips, this can last about 15 to 30 minutes, but it should not last more than 1. Okay. Stage 2 is the pushing phase. So we're going to, like we broke down stage 1 into 3 different phases: active, latent, active, and transitional. We're going to break down stage 2 into a latent and an active phase as well. Okay. So the second stage is divided into these, and we're looking at here really the end result is going to be the birth of the baby. So we've got this latent, where once the mother is fully dilated, we've got a period of rest, which it feels like, honestly, seconds that you have this latent period, because that's literally what how long it lasts. In this part, the fetus further descends, and this is happening, mother begins to relax a little bit, which then allows the baby to go down. And then all of a sudden we have this Ferguson's reflex at +1 station. So we had this strong urge to bear down. This Ferguson's reflex is the presenting part of the fetus presses down at the pelvic floor, like I said, at this +1 station. This Ferguson's reflex releases a huge amount of oxytocin, and that triggers the mother's urge to push. You see this more commonly in low intervention births, where we haven't stunted mother's ability to feel that, but you can still feel it with a very accurately dosed epidural. Crowning is called, and that's why there's a crown on this slide. Crowning is when the largest or the widest part of the head descends into the vulva. So here on this next picture, figure D is really showing that crowning aspect, okay? The vulva has completely distended to allow for that wide space, okay? During the laboring, in stage 2, the positioning in the laboring mother really has a couple of different factors. If the woman has not had like an epidural, we don't have a ton of interventions, she might choose a different position. And when you're talking about places outside of the United States where we have typically less medicated deliveries, you start talking about things, and we'll get into them in, I think it's Unit 3, where we talk about the alternate birthing centers, where you have a stool, where women have birthing chairs, where they really were allowed to, or they have, what are they called, like ropes and scarves, that they could actively use other parts of their anatomy to help and aid in pushing this baby out. I was able to get on my hands and knees with my epidural with baby number 2, which aided in Abby being able to twist and turn through the birth canal. Women can squat, they can get on their knees, they can sit, they can recline, or they can lie on their sides. The lithotomy position is the one that you see more traditionally in the United States. This really is designed to assist the physician or the practitioner with complications. So in this kind of situation here, the woman is at the edge of the bed, her buttocks completely off the edge, kind of barely on the edge there, and the legs may be in stirrups, or more commonly now the legs are being held up by the medical staff, and as well maybe by her support person.